I'm Dr. Rick Wild. I'm the Regional Chief Medical Officer for CMS for the Atlanta region, which covers the entire southeastern United States, including Georgia. Bottom line, take-home message, if there's one thing to remember, make sure you have our website embedded in your mind, cms.hhs.gov/EHR incentive programs. Make sure you put the S, because we have more than one. We have Medicare and Medicaid. And that will get you more than the information I'm going to give you today. It will give you copies of the regulations if you like to read regulations. It will even give you PowerPoint, some of which, some of these slides might look familiar if you go to that. But as I said, I like to jazz it up a little with a few things, so I'll give you an overview first. Because I think it's important when we talk about regulations. And did all of you hear Janet Marcia-Broda today? No? Okay, Janet's a great person, and she's got the insider's view in Washington, D.C., and she's free to speculate on things that will happen on Capitol Hill that I will not speculate on, because I'm a federal, non-political employee, and I will stick to the law and the regulations and won't give you any inside the beltway punditry unless I slip up. But our vision for CMS, and I always start with quality improvement, is we want to do the right care for the right person every time. And that comes not from CMS, but the Institute of Medicine, their health system for the 21st century report. And they initially had 6 domains of improving care. Safe, effective, make it efficient. You can certainly believe that Medicare, Medicaid are very interested in efficient care, patient-centered, timely, and equitable. Actually, our prior administrator, Dr. Donald Berwick, who many of you may know was one of the pioneers in healthcare improvement, we helped reconfigure those 6 domains that the Institute of Medicine came out with into what we call our 3-part aim. Better care, reduce per capita cost, and improve population health. But you can see that all of those 6 domains are represented in the subparts of our 3-part aim. Now, HIT overview. One thing I want to make very clear, there's a lot of atmospherics, a lot of noise about the Affordable Care Act and what's going to happen, blah, 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 blah. Our HIT incentive program, our electronic health records incentives, et cetera, are not part of the Affordable Care Act. So don't panic if you hear, whatever you're hearing. This came out of the HITECH Act of the Recovery Act of 2009. And that established our EHR program for meaningful use of HIT. And it authorized $29 billion, that's B with a B, billion with a B, dollars of incentives to be given to hospitals and providers that achieve meaningful use. And certainly the medical literature is demonstrating all the time that hospitals and physicians with automated notes and records, order entry, clinical decision support have fewer complications, lower mortality rates, and lower costs than those who do not use HIT. Now our vision, our 50,000-foot big picture vision for meaningful use is as follows. You all know now when people are we're going to focus on stage 2. We are currently in stage 1, and everyone who starts meaningful use starts in stage 1, stays in stage 1 for 2 years, and then progresses on to stage 2. And stage 2, for those who've already been in the program now for 2 years, starts October 1st of 2014 if you're a hospital, and if you're a physician. Physicians use calendar year, hospitals used our federal fiscal year, would start in January of 2014. And you can see that we started stage 1, which was the first steps in the water, which was data capturing and sharing and just getting people on board with HIT. Stage 2, meaningful use stage 2, advances that to more advanced clinical processes and more quality metrics as well, and more information and data sharing. And then, of course, stage 3, which has not been published yet, but of course, the advisory committees in Washington are already looking at stage 3, will go towards more robust measures to improve clinical outcomes and achieve those domains of meaningful, our quality metrics that you just saw in our three-part aim. Now, this just demonstrates where we were, where we want to go. And you can see that initially we had a big barrier here in infrastructure. Before we got into HIT and meaningful use, we had this whole HIT barrier. We didn't have the infrastructure, and we had episodic, uncoordinated healthcare. Now, as we move towards better use and sharing of data through electronic healthcare, we're going to be moving towards more accountable care and more integrated care. And we still will have a clinical care knowledge barrier, though, and hopefully as we get up towards integrated care, which will be more in the stage 3 area, we'll start using what we're learning about our patients and data sharing, et cetera, clinical information prompts, et cetera, more smart systems to really improve healthcare, make it more efficient, more affordable, improve outcomes. This is a rather busy slide. It just goes into some of the domains, and once again, we see the meaningful use barrier over there on the left, that red line, and we have the domains of cost containment, quality improvement, administrative efficiency, and population health and research. And of course, most physicians in most hospitals up and recently didn't even consider the health of their communities or population health. They just considered quality patient by patient by patient. And as you know, we are in an inflection point in our healthcare system where hopefully through the Affordable Care Act and expansion of our health insurance to more and more people, we will have more and more people that have access to quality health care and access to health care in general. So HIT is going to have a huge impact on where we go in our programs going forward. And some of you already sensed that from Janet's lecture keynote speech this morning. And you can see that we'll be using HIT to improve all of these areas in reducing duplication and improving cost effectiveness and coordinating care and getting better quality performance and better outcomes and reducing administrative cycle times. I mean, eventually, there's a lot of physicians right now in hospitals spending a lot of time just submitting claims and everything else, but you can see that it wouldn't be too far of a stretch to have that information coming in right from a patient summary chart. And then, of course, we can start using meaningful use to improve population health. Right now, as I said, a physician knows his practice patient by patient, but very few physicians without an electronic health record could tell you how many of my diabetics are in control, how many of my patients that have hypertension are achieving better blood pressure control. Whereas in using an electronic health record system, whether you're a physician or a hospital, you can pull down and query that system and look and see exactly what results you're achieving. And then, of course, down the road, we get to improving health disparities, improving population health and public health, and reducing unnecessary costs, because about 30% of all the healthcare costs in the United States are due to procedures, diagnostic and sometimes therapeutic procedures that frankly are not necessary and don't add value to the patient or the patient's health. And that's the topic of a different lecture. But we can do a lot towards making healthcare better quality, and more efficient. And electronic health records are definitely part of the foundation for that. Just another little bit of a think piece here. Where are we right now if you talk about a medical home? Well, we're probably at medical home 1.0 in most cases. A physician practice or medical home may be doing or probably is doing e-prescribing these days. They have individual patient care plans. They're able to coordinate care a little bit, but they're not talking to all the other downstream people that are involved in transitions of care, whether it's post-acute care or skilled nursing, et cetera. and they probably have an electronic health record. If we go to Medical Home 2.0, and some medical homes and certain accountable care organizations are already into this mode, we can see that we have the patient registries that I talked about. We have clinical decision support with e-clinical decision making. We have the electronic patient access and communication through their patient portals and their eligibility system interface. That's going to be more and more important as more and more people have health insurance. Two-way quality reporting between the physicians and the systems, letting each other know how they are achieving their quality benchmarks. Population health, biosurveillance, chronic disease management, et cetera. Now we get to Medical Home 3.0, which is probably, I'm not necessarily saying this is meaningful use stage 3, but it's probably down the road there. And we have e-health compatible, we have information exchange between providers, and we might even have, and this is not too far off, Janet mentioned telemedicine, and I'm a huge believer that telemedicine is going to be a huge disruptive technology. I use disruptive in a positive way, technology for healthcare. We're going to change the paradigm. Maybe we'll have more and more virtual doctor's office visits. I know the Georgia telemedicine network, which is expanding throughout the Southeast, is able to get access to care for people in southern and southwestern and southeastern Georgia, which is extremely rural. I mean, we are talking backing up against the Okefenokee Swamp down in Raycross. I don't say that jokingly, way down on the Swanee River. There's not a lot down there. And now young children and people that need specialty and tertiary care can, through telemedicine nodes down there, connect and get tertiary care at some of Atlanta's major academic tertiary medical centers. So that's a huge improvement in access to care. Home health, biometrics, there are smart Band-Aids now that you can actually transmit telemetrically a patient's heart rate. You can transmit their blood pressure, you can transmit their weight if they can get on a scale. So actually with those three parameters, physicians can monitor patients that are at risk for exacerbation of heart failure as their weight goes up, and because they're eating more anchovy pizzas, taking in more salt or whatever. That's a joke, that's a medical joke. We used to call heart failure the anchovy pizza syndrome. But their weight's going up, their blood pressure may be going down, their heart rate may be going up. Well, that's the time to send a home health nurse out to that house or get that patient in to avoid a readmission, which all of you may know in the hospital side, we certainly have a robust readmission reduction program. So in many ways, telemedicine and electronic health may pay for itself as we go forward. And once again, another busy slide. This just recapitulates where we're going from episodic, non-integrated care towards more accountable care, towards more integrated health care throughout the system, throughout the regions, throughout the states. And summary, what's our return on investment for electronic health information? It gives us our three-part aim: better outcomes, lower costs, and improved population health. That's our return on investment for that $29 billion that we are not just giving it out because we just want everybody to have an electronic health record. We want people to use it to improve care and make care more efficient and reduce healthcare associated avoidable conditions as well. So let's talk about the final rule. What's in the final rule? We made some very minor changes to stage 1 of meaningful use. I'm going to focus on where we're going in stage 2 of meaningful use. New, more robust clinical quality measures are in this new rule. Payment adjustments and hardships, exemptions as well, because even though we talk about incentives, and we've put $29 billion on the table for incentives, as you know with any government program, first come the incentives, first come the carrots, and then come the sticks. Those are called payment adjustments. So we're encouraging people right now to take the carrots and achieve meaningful use. And then if they haven't achieved meaningful use in 2015, the payment adjustments come in. And we'll talk a little bit more about that timetable. So what does it mean to you beginning in 2014 or beginning October 1st if you're a hospital? Providers, hospitals that have already been participating for 2 or 3 years will need to move on to stage 2. Early adopters have been on stage 1 now for 3 years because we extended that for a year previously. But once you've been on it now for 2 years, you have to move on to stage 2. Stage 2, we hope, will have additional measures to improve patient care through care coordination, more patient engagement we'll talk about, and clinical decision support. And we hope the bottom line is we'll save money, we'll save time, and we'll save lives. And now, what does this mean to you in terms of dollars? Are most all of you Georgia providers? All of you have a Georgia nexus here? I apologize, this is a screenshot. You may not be able to see it. But these are national, but I'll give you the Georgia figures as well. Looking down at the bottom corner here, nationally as of June, and if you go to our website, these slides were put together a while ago. It takes us a little while to accumulate the up-to-date data. I think you'll get some later. We publish this about every month on our website with a little bit of a time lag, reporting lag. We're already up to, in the Medicare incentive program, $9.3 billion have been paid out to both eligible professionals and eligible hospitals. And you can see 218,000 eligible providers have been paid, if you count, that's physicians, but if you count all the dentists, optometrists, podiatrists, chiropractors, we're up to 244,000 eligible providers. Now remember, hospital-based providers are not eligible for receive Medicare incentive payments with some very small exceptions. But you can see we've got a lot of doctors on board. There's around a little shy of a million doctors in the country. Now, not all doctors, once again, because they're hospital-based, are eligible. But that's just for Medicare. And in Georgia, as of June, we have paid over 5,490 physicians. There's roughly 10,000 physicians, 9,000 plus physicians in Georgia. 5,490 have already received incentive payments for Medicare. We haven't talked about Medicaid, and that's 200, and that also includes hospitals. These are providers, so carve out a few hundred for the hospitals. But $255 million in Georgia alone has been paid out under the EHR incentive program. Medicaid is a separate program. You can't get incentives in both. You have to elect one or the other. And you can see once again that in Medicaid, we have also paid out $5.8 billion as well. Add that together, you see we're well up to $14 billion, $15 billion of the total money on the table. Remember, that's paid out incrementally. So a lot of people are getting incentive payments, and most people are on the glide path towards achieving meaningful use. I think the figure is roughly 85% of all hospitals, that would include critical access hospitals, are on that glide path, and more are joining all the time. And don't quote me on that figure because that's rapidly changing. All these figures here are a moving target. And you can see this is just a snapshot of people joining every month. If you went over to the far side, you'd see how many new providers have just received those payments in the month of June, for instance. And in the Medicaid incentive program in Georgia, we have 2,600 providers, 2,675 providers that have been paid $149 million.